Racism and health, the life expectancy gap. Have you ever wondered why black people don't live as long as white people? It's true. When I was born, my life expectancy was 6 years greater than that of a black male born at the exact same time. 6 years. After 50 years of racial progress, the gap remained exactly the same. 6 years. It appears that being black is just as bad for your health as being a smoker. Must be a genetic thing, right? Guess again. Although white and black people have different genetic risks for different diseases, the gap in overall life expectancy is not explained by genetics. It's explained by a myriad of social factors, from environmental exposures to socioeconomic deprivation, to differences in healthcare, and even to bias in funding of medical research. In other words, to racism. Let's take a look at the facts, starting with COVID-19. The COVID-19 pandemic is continuing to ravage the country, with more than 6 million Americans infected and nearly 200,000 dead so far. When we look closely at the numbers, though, we find evidence of something even more troubling. Black Americans are dying from COVID-19 at about 3.6 times the age-adjusted rate of white Americans, more than triple the mortality risk. When looking at the 10 nations of the world with the highest number of COVID deaths per population, if Black America was a country, it would be number 1 in the world for its COVID death rate. Number 1. What could possibly explain this? Again, this is not due to some sort of genetic defect. The culprits are clear when we review the facts. They are the same factors that create the life expectancy gap. First, we know that black people are more likely to live in environmentally challenged neighborhoods where their health is already threatened by air and water pollution, if not the lead in their pipes. Plus, they have less access to health care, and the care they do receive is often below standard, which we will get into shortly. And they are more likely to have jobs that don't allow for social distancing, which means they are disproportionately the essential workers on the front lines of this pandemic. We should not be surprised that racial disparities appear in COVID survival. After all, black adults are more likely to die from heart disease, strokes, and breast cancer. Black mothers are more likely to die in pregnancy and childbirth, and black children are 10 times as likely to die from asthma. Believe me, nothing puts a crimp in your life expectancy like dying in childhood. As the CDC puts it, African Americans are more likely to die at early ages from all causes. That really doesn't sound like a genetics thing, does it? In fact, these health disparities can be explained by the impact of racism at 3 levels. First, our government policies. The way we write laws and structure budgets creates the conditions for people of color to live sicker and die sooner. Second, the bias of our healthcare system. When doctors and nurses hold racist beliefs, it shows up in the way we provide care. And third, the physical toll of the constant stress of racism. Let's start by looking at governmental policies. Nobody wants to raise their kids in a neighborhood where the air you breathe makes you sick, but people of color have often found themselves living in the least desirable places because of housing discrimination. A great example of private discrimination was Donald Trump and his father, who prevented black people from buying apartments in white buildings in the 1970s. They just had to go live somewhere else. A famous example of governmental discrimination was the building of the freeways in LA in the 1950s, when they carefully went around the white areas and plowed right through the black neighborhoods, like Boyle Heights. What do you think is the air quality beneath a Los Angeles freeway? As a result, black people now are 3 times more likely than white people to die from air pollution. The bias even shows up in our research budgets. In the US, sickle cell disease affects 3 times as many people as cystic fibrosis, yet somehow the federal government gives 11 times more funding for each cystic fibrosis patient. Not to mention private foundations which give a whopping 440 times more funding for cystic fibrosis than for sickle cell disease. Is it a coincidence that sickle cell anemia is a genetic disorder of black people, while cystic fibrosis is more common among white people? This brings us to our second level of racism, the health consequences of individual bias. When doctors and nurses hold racist beliefs, it harms their patients. For example, from the very beginning of America's healthcare system, there has been a myth that black people feel less pain than white people. That's how J. Marion Sims, who is now known as the father of gynecology, justified performing experimental surgery on enslaved women without anesthesia in the 1840s. That myth persists today. In a survey from 2016, 25% of white medical students and residents believe the myth that black people have thicker skin than white people. How does this kind of belief impact medical practice? Black people are consistently less likely to get adequate treatment for their pain. One study looked at children with appendicitis, and it found that even black children are less likely to get pain medication than their white peers. Let's move on to heart disease, still the #1 cause of death in America. If you have heart disease, you might need a diagnostic procedure called a cardiac catheterization, but black people are less likely to get this procedure than white people. And if they do get it, they are less likely to get treatment of the obstruction. A multitude of studies have demonstrated this bias. The clincher was an ingenious study done at a hospital in Cleveland. They created a committee of physicians who would review every cardiac case to decide if catheterization was required. The members had access to every piece of information about the patient except one, their race. When the decision makers were blinded to the patient's race, the race bias disappeared. Every patient was treated the same. So if I don't know that you are black, I will give you the same treatment that white patients get. Are there any other examples of a racial health disparity? Oh my God. In fact, there is a vast body of research on this topic, and it all points in the same direction. Doctors and nurses treat patients differently based on nothing more than their race, and it puts black people at a severe health disadvantage. Here are 20 pages of citations from this body of research. Here is a study on racially biased treatment of congestive heart failure and pneumonia. Here is one on lung cancer, one on childhood asthma, use of cardiac procedures, psychiatric diagnosis in adolescents, colon cancer treatment, treatment of Medicare patients, the use of clot buster drugs, hip and knee replacement surgery, cancer research, getting a kidney transplant, the doctor-patient relationship, treatment of HIV, diagnosis of schizophrenia, treatment for breast cancer, treatment of dialysis patients, use of psychiatric medications, treatment of pain in the emergency department, life-saving treatment in the ICU, and breast cancer survival. Wow, I'm actually out of breath. Is there any nook and cranny in my world of medicine where healthcare professionals practice without racial bias? It doesn't seem so. In fact, it is one of the most well-proven conclusions that I have ever seen in my evidence-based medicine career. And what is especially notable is that most doctors and nurses are not trying to be racist and would be shocked to learn that they behave this way. This is a great example of subconscious bias, and it is widespread and potent. Even more painful is the realization that I am not immune to this subconscious bias and must have surely practiced this way myself. It is a hard truth to accept. Now we turn to the third and final underlying issue, the physiological impact of racism itself. That's right, the day-to-day experience of being a person of color in America creates persistent stress, and that stress has health consequences. In the same way that a steady drip of water can wear away stone over time, there is a constant drip, drip, drip of racism. Being denied a mortgage, being followed at the grocery store, being pulled over by a cop, seeing the steady drumbeat of news stories about unarmed black men killed by police that wears down a person's well-being. Recent research has shown that this phenomenon, called the weathering effect, has real consequences on health. So we can clearly see that racism is toxic to health. We see that it shows up in environmental exposures, bias in research, prejudice in healthcare settings, and even the daily grind of persistent racism. Yes, we may say that all lives matter, but we don't behave, most of us, as if black lives matter. What can we do about it? Plenty. We can educate ourselves to better understand the bias we might not even realize we have. We can advocate for better policies that address structural racism at the root. And we can use the power of our vote to elect leaders who will champion these much-needed changes. And we have a wonderful metric for our progress. When the 6-year gap melts away, when a black baby boy or girl has the same shot at living to a ripe old age as a white child, then we will know we have climbed the mountain. Let's climb it together. Hi, I'm Nate Link, and I hope you were enlightened by this video essay on racism and health. For more video essays on economics, health, and national leadership, please check out my website at snickersnack.com. Thank you.